Yeah, good afternoon, everyone. And I want to thank the organizers for giving me this opportunity. So, I'll be talking on management of portal vein thrombosis in liver transplantation. Now, at some point in the initial period, it was a contraindication, but no longer. And preoperative portal vein thrombosis can increase the complication rate in surgeries because it increases the complexity of the surgery. But now with the current techniques, in almost 90-95% of the patients, one can sort it out during the surgery. The methodology and the success of management may be governed by the extent of thrombus, and we all, I won't be going into detail of how to classify it, but we all know, I mean, like it's the Yerdle 2, grade 2, 3, and 4, which are the most common ones which we encounter in our day-to-day practice. So I'll give this talk under the following heads. Our data, I'll talk about preoperative PVT, post-op PVT, and difficulty faced in pediatric liver transplant patients as well. Amongst the adult patients, about this is our data, about 856 transplants, of which 54 had PVT, and uh, very few, around 20%, 20-25%, we detected intra-op. Most of the PVTs you can detect pre-op, but if you have a recanalized portal vein thrombus, very eccentrically placed, sometimes it gets missed on the CT, and only during the surgery that you recognize it. And amongst our patients, the commonest group was hepatitis B, in which we had this portal vein thrombosis. So, what are the maneuvers one has to solve this? One is that if you have a usually when you have a detected portal vein thrombus during the surgery, not detected on preoperative CT, usually it's a recanalized portal vein. If you have a good flow, then sometimes doing nothing makes sense. I mean, you can just use that very portal vein to do the anastomosis. But most commonly, aversion thrombectomy, then sometimes portal vein resection with or without venous graft, or an alternative inflow like a cavoportal hemitransposition, which something is not very successful, I would say, but it's one of the options available. And lastly, arterialization of the portal vein. So in our patients, about the commonest what we have done is suction thrombectomy, and sometimes we have used a new portal vein reconstruction. So this was one such example, Yerdle stage 1 patient with a eccentrically placed portal vein thrombosis. On the preoperative CT scan, you can appreciate that the thrombus is extending just up to the proximal superior mesenteric vein. The splenic vein was spared. And we did a aversion thrombectomy here. While doing aversion thrombectomy, few basic points which one needs to be careful about, that most of the times blunt dissection will help, but if you are on a preoperative CT scan, you are seeing calcification in the wall of the portal vein, better to use sharp dissection with scissors, because while doing blunt, invariably the portal vein will tear, and if it tears behind the pancreas, then you are done for. It's becomes a really complicated stuff then. So very carefully see the preoperative CT scan. There should not be any calcification, and then this can be easily averted out. And if the flow is good, then in this particular patient, this is a post-operative scan. You can see a good flow was established. So then for a Yerdle 2, in this patient, sorry, okay. Uh, so you can see more than 50% of the portal vein thrombus is almost completely occluding the portal vein, reaching up to the proximal superior mesenteric vein. Again, the splenic vein is spared, and you have a big shunt also, linorenal shunt also present. So for such patients, in this patient, the thrombus was densely stuck, and a good flow was not being established. So we decided to reconstruct this portal vein. So here we are bringing it below the pancreatic neck. We dissected it, brought it all the way down to the superior mesenteric vein, splenic vein junction. This is behind the pancreas. We have removed the portal vein through the tunnel, and then we always do this marking with a sterile pen. It's once you have palpated the thrombus where it ends, it gives you a good orientation. And so this is a clamp applied, and now the portal vein is excised, and we had a cadaveric vein graft for this. We also preserve from a lot of adults cryopreserved vein grafts. We'll explant the portal vein, we'll keep that as well. But here we had a cadaveric vein graft, luckily, and that we then used to establish the inflow. This is a jump graft type of a situation which you can see. So this is a CT scan post-op. You can see a good inflow established into the liver. Then you also come across sometimes situation where you have like Yerdle 3, where both the in the SMV the proximal centimeter was involved. You can see calcification in the portal vein, again a very complex. You should not, most of the times when you are doing if you are trying to attempt a aversion thrombectomy, you will end up tearing the vein. And the splenic vein is also, thrombosed here, and you can see calcification in the splenic vein as well. So we were dilly-dallying this patient for quite some time, but he started decompensating, and then we decided to use a conduit. Unluckily, we did not have a good cadaveric vein available. In fact, our cryo fridge conked out just a few days before this this thing, so most of our grafts were not of good quality. So we ended up using something similar to a PTFE graft. This is a bovine graft which we use. So what we have done here is we have taken the inflow from the left renal vein. So this is the right now looping of the superior mesenteric vein till the point where there is no thrombus. It's a slow meticulous dissection which one has to do, and then again orientation sutures. And so we took so this is the diameter of the vein we are measuring, and then we are using this graft. It is made up of bovine material. It's a woven graft, and Integrad, that is the name of the graft. And then we did a side to side anastomosis, and then the left renal vein has been exposed. Again, orientation marks have been put on the left renal vein so that you don't get a kink. And then another graft was used to connect to the left renal vein. After removing all the clots and from inside the graft, then we connected the two from the SMV and the renal vein. We connected the two grafts, and in a side to side manner. And then this main graft was then used for the portal vein anastomosis. So the patient did well initially in the post-operative period, and did not have any of the complications related to the vein graft, but eventually had a septic complication, and about 3 months later the patient succumbed. He had gone home, but then developed some septic complications and then died, but the graft was functioning right till the end. So it is technically feasible, but obviously preference would be to use natural vein grafts. So this is a portal venous anastomosis which was done, and this was the post-operative CT. You can see a good inflow established in the. This is a graft going from the renal vein, from the SMV, and so good inflow established. For Yerdle 4, we have never done a transplant for a Yerdle 4 where you do not have any other option other than a portocable hemitransposition or arterialization of the portal vein. But when I was working with Dr. Gupta at that time, we used a gastroepiploic vein as an inflow graft. And here you can see this is one of the photographs where this was a temporary shunt made to the left. The graft was so long that you could be from the gastroepiploic vein to the left hepatic vein. This is a temporary portocable shunt made, and later on this very vein was used for inflow into the new liver. and worked well for about a couple of years. Then the patient developed portal vein thrombosis, but the patient is surviving, but it eventually thrombosed off. So non-physiological portal vein reconstruction problems are that there will be a residual portal hypertension, altered cardiopulmonary dynamics, prolonged post-operative recovery, and option is obviously a combined liver intestine transplant, but again a complex um, option, not a straightforward option. So these are contraindications. You can't see any inflow, you cannot establish, and there are no big collaterals also to get an inflow from. So early experience, there was a higher post-operative mortality, but now with the current techniques available, morbidity may increase a bit, but mortality is not really increased. A few slides on post-operative portal vein thrombosis we encountered in pediatric. Initial part of our series, we had a problem in the pediatric transplants. We had a higher thrombosis rate in the post-op period. So then we sorted out our techniques. Shunt ligation is extremely important in pediatric, particularly when you are taking children less than 1 year old. They'll invariably have a linorenal shunt. So we ligate the shunt right at the renal vein level after mobilizing the colon away, and we ligate and disconnect it as well, so that the thrombus doesn't travel back into the splenic vein. And also we did develop, Dr. Arun is here, he published this paper on intraoperative portal vein stenting through the umbilical vein approach. It's a very innovative technique where we recanalize the umbilical vein, and in case of a thrombus, if we encounter in the during the surgery, we would use this recanalized vein to pass a carotid stent through it after doing a suction thrombectomy. And this invariably works. We have never really left the operation theater with a non-flowing portal vein in the pediatric population. So this is the umbilical vein which has been catheterized. Right now we are doing a suction thrombectomy. If you can appreciate the lower down, that's the portal vein, main portal vein. The catheter has gone into we've done a suction thrombectomy. So usually in pediatric, if you are having this problem, it is usually an angulation problem. Somehow you're not got your portal vein angulation correct, because of which this thrombus will occur. So better in such situation only, better to put a stent across, because that will reorient the portal vein and that correct that angulation problem. So I think I skipped it. So we will use, and after at the end of the procedure, we put a KMP catheter and we'll put a hemorrhoid band on the umbilical vein to hold it in place. So it's easy, through this we can give heparin in the post-operative period, and on day 4 or day 5 after doing angiography, portal venography, and we can just pull it in the bedside, and this hemorrhoidal bands will prevent the bleeding to occur. So we published this in Transplantation, and there were 8 patients where we did this portal vein stenting, and very excellent patency rates. Only 1 patient had a thrombus in the late post-operative period, and then we analyzed our data. This is at the time of publication of our paper. So there were 188 patients where we analyzed. We used reduced left lateral grafts for all patients less than 1 year olds, so we found there were 13 patients in total where we had a portal vein thrombosis complication, and about 8 were intraop where portal vein stenting was done. Later on, we changed our technique as well. From continuous suture, we went to interrupted sutures in the portal vein, and now in the past 120 or 130 patients, we haven't had any portal vein thrombosis problem. This is again one of the patients where a cavo-portal hemitransposition was done. I have never done it. This was at the time of when I was in Dr. Gupta's unit. At that time, we did this thing, cavo-portal hemitransposition. Again, it worked for 2 years, but later on, the child developed complications of portal hypertension, and eventually 3 years later did not survive. So all the non-physiological shunts, they have their residual problems. So one should try and do transplants for where you can establish a natural inflow. So I would like to conclude with these key points that insulin directed recanalized portal vein thrombosis can be left as such if portal vein flow is good. Carefully done eversion thrombectomy, it works well. And as I said, occasionally you will have to use sharp dissection, do that. It is always helpful. Options of using jump grafts should be planned preoperatively. It should be well planned, and augmenting portal inflow with shunt ligation is an important step in pediatric liver transplant. Thank you.
Nice presentation, Dr. Nirav.